Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today I'm talking to Andy Haines, or I should say Professor Sir Andrew Paul Haines, but good to talk to you, Andy. Now, let's bring it back to the very beginning. What started your interest in medicine?
Well, that's an interesting story because I had no one in my family who had been to university, and but the key person in our family's life, or a key person, was our GP, the general practitioner. She was a really outstanding GP. She worked alone, quite unusual quite unusual to have a female GP at that stage. She delivered me in a nursing home. I gather I was at difficult delivery. And she looked after me in my childhood when I had pneumonia at home. She looked after me at home and so on. I was so impressed by her. I think that consciously or subconsciously, I decided at an early age I really wanted to become a doctor. Really, I think modeling myself partly on her. And one of the wonderful things was after she retired and I started medicine, I went back to see her. And I said, look, I want to thank you because you really kind of shaped my life. And it was your wonderful example and your impact on my early life that influenced me.
Well, then you went on to medical school, and then what took you towards your postgraduate career? You went and worked with someone in South Wales, I believe.
I did. After various jobs, I worked in Jamaica for a few months in the emergency department. I worked in Nepal working on tuberculosis treatment. But I felt quite inadequate and poorly trained. And I decided I wanted to get more training. I did a few locums and I was a bit directionless. And then I happened to be working as a locum registrar at Northwick Park Hospital in Northwest London. And there was a Medical Research Council unit, epidemiology unit there. I went to see the director, Tom Mead. And I said, I'm sort of vaguely interested in research. I don't really know much about it, but I really like to do it. And he said, I've got an interesting job for you. Working with Dr Julian Tudor Hart in Glyncorrwg in South Wales, where he's integrating epidemiology into general practice. And so I went and worked there and did my GP traineeship there, but also got a grounding in basic epidemiology, but this great vision that Julian had of integrating population health with individual clinical practice with individual patients in a very, very deprived community, of course, a former mining community.
So tell us a little bit more about your day in practice in Glyncorrwg.
In Glyncorrwg, I mean, Julian was a very charismatic person, a tremendous thinker, always thinking, always posing interesting questions, a tremendous intellectual leader, in a way, kind of head and shoulders above many of the other more narrowly focused people that I've worked with. So obviously there was a lot of clinical work involved, and there we were working obviously in the health centre, but I was also on call. So in the evenings I'd be on call not just for that practice, but also neighbouring practices. So you'd be driving up and down the valleys, going to a whole range of different problems. Obviously you're quite isolated, so you had to think quite carefully whether to send someone into hospital or not. But the other thing that was really striking was, of course, that many internationally renowned people were making their way to his door, to Glyncorrwg. People would turn up from all over the world wanting to understand and hear about the work that he was doing. And he was a very early exponent of involving the whole community and involving the patient. So we had patient committee. He was very open in terms of communicating with the whole population. And of course, as you would probably recall, he was eventually successful in measuring the blood pressure of the whole population. In fact, the last patient, the one person in the village he hadn't measured, he eventually cornered him and said, I want to measure your blood pressure. You're the only person who hasn't had your blood pressure measured. And very reluctantly, the man sat down and the blood pressure was something like 200/120. And he was completely asymptomatic. So, that was quite an eye-opener for me, and really opened my eyes about how to integrate preventive care into the busy clinical practice workload.
Well, that relationship between Tom Mead and the MRC and general practice. That was way ahead of its time.
It was indeed.
When did you move towards epidemiology?
Well, I think it was really working with Julian. Of course, working in Nepal, I'd seen that a lot of the tuberculosis that was coming to me in a clinic, you know, it was all happening in the community. And I wanted to get out into the community and look for, go case finding for people. But that wasn't possible. We didn't have the resources. But working with Julian, of course, he very clearly indicated the practical uses of epidemiology and how you could integrate it with clinical medicine. So that very much fostered my interest in epidemiology as a scientific discipline. When I went back to Northwick Park in London, I worked with Tom Mead on the Northwick Park Heart Study, which was looking at the role of the clotting factors and the hemostatic system in heart disease. But of course, being a GP at heart, I obviously wanted to spread my wings a bit and to also integrate epidemiology into primary care. And so when I got a practice in Harlesden in northwest London on a housing estate there, I started to take on new partners and integrate research into a very busy clinical setting. So doing studies looking at, for example, we looked at the epidemiology of effusions, middle ear effusions at one point, because I was kind of intrigued by that. And we found a lot of middle ear effusions in children who are apparently normal. So we knew it was a spectrum. And we did a whole host of other studies. We did a lot of work, particularly with the late Professor Paul Wallace, on detecting heavy drinkers in general practice and intervening and showing that even a brief intervention by a GP could influence the biochemistry, what people said they drank, but also there were objective indicators that we were having an impact. So a whole range of different studies, and got very interested in not just describing patterns of ill health, but also intervening, of course, using mainly randomized trials, but not with drugs so much, but more with behavioral interventions.
Now, you're involved in another organization which nowadays people have slightly forgotten about, and that's the Medical Campaign Against Nuclear War. That was a very interesting time.
It was indeed. And of course, we're now returning to a time of great international tensions and almost back into the Cold War, really, almost a hot war. So in the early 1980s, I actually worked in California for a year on sabbatical from the MRC. But when I was there, I started to hear about, well, I became very aware, of course, of the nuclear tensions and Cold War. In 1982, I think it was, there was a meeting at University College London, an inaugural meeting to set up something called the Medical Campaign Against Nuclear Weapons, which was really the voice of health professionals speaking out. I was very much influenced emotionally also by seeing some of the testimonies of the Hiroshima survivors and the fact that they had the courage and the fortitude to recover from their extraordinary experience. Seeing some of those photos of Hiroshima and Nagasaki really made it very clear to me that as a health professional, I had a duty to speak out. And we couldn't just accept the tensions of the Cold War. We had to also try to communicate with our, what were then Soviet counterparts. And very soon after that, I was invited to a meeting in Airlie House, which was in Washington, where a group of physicians from the West met with Russian physicians. And that was organized by a famous cardiologist, Bernie Lown, who worked with Eugene Chazov, who was Brezhnev's personal physician and a cardiologist. And they collaborated together on cardiological research. And they were able to use that as a basis for overcoming some of the incredible distrust and sometimes, very, very dangerous levels of confrontation. And we were able to go to Russia, for example, the USSR, and speak to people about nuclear war, because one of the criticisms at the time was that all the evidence and all the information was coming to us in the West, that the Russians knew nothing about it, and they were being told that they could win a nuclear war. And we were able to speak at meetings, which we were televised and so on, and show that we could speak openly about the effects of the medical effects of nuclear weapons. So we tried to keep it very medical. And that's how the IPPNW, the International Physicians for the Prevention of Nuclear War, was founded, which got the Nobel Peace Prize in 1985. Now, sadly, of course, we didn't complete the job. We weren't able to, because once the Reagan Gorbachev summit had occurred, everyone thought the problem had been solved. but of course it hadn't, because the weapons were never abolished. And so now we're back in a very, very dangerous situation indeed.
So let's bring it back to the academic track and the London School. Tell us how that evolved.
Well, I was in practice and I was a professor at University College London in primary healthcare, the inaugural professor there, and was quite happy in my work. I also had a three-year position, part-time position with the NHS executive, working as regional director of research and development, which I enjoyed very much. But around about 2000, I had a call from a colleague who said, oh, the London School of Hygiene and Tropical Medicine are looking for a new director and they want to appoint someone from outside the school. And so because I'd worked quite a high level in the NHS and also had worked at WHO and internationally, anyway, it was an interesting process of being selected. My boss was Linda Chalker, Baroness Chalker, who was Thatcher's longest serving minister and a tremendously committed person in terms of international development. I wouldn't say that necessarily our politics we would always agree with each other, but I'm a tremendous fan of Linda Chalker, and it did show me how people who you may think, well, politically we're very different, you can work very constructively together as long as there's mutual respect. And indeed, Linda has got a tremendous commitment to improving development in Africa, and so it was actually a very positive relationship. And she was in a sense, my boss, because she was the chair of the board, which ultimately appoints the director. So I did 2 terms, pretty well 2 terms at London School, and then decided it was time to step down, because I wanted really to focus on what has become my major concern now, which is climate change and health and environmental change more generally, and the impacts that's having on human health, and how that will increasingly make it difficult to achieve good health in the future. So that's my focus now, is documenting that and also thinking about solutions.
Before we move on to climate change, talk a little bit about your international work, because you've had remarkable achievements in primary care, particularly internationally.
Well, I never really practiced in primary care internationally. I mean, my work, as a young doctor, was in TV, for, vertical program actually. But at University College London, we had an opportunity to run international course, which attracted GPs from many parts of the world. Worked with my now wife, Anita Berlin, who was a major leader in those international courses, and because of her language skills, she's particularly linked with the Spanish-speaking world. But I also had the great good fortune to meet someone called Carlos Dora, who became quite a senior WHO person. He was a primary care physician from Brazil, and he actually came and worked in my practice for a few months in Northwest London, and he invited me to Brazil. And that was the beginning of quite a long-standing program of interchange with our colleagues, particularly in Rio Grande do Sul, which is in the southern part of Brazil. So it's closer to Argentina. But I was very fortunate because I got in at the beginning of the Programa de Saúde da Família, which is a family health program of Brazil, and was able to visit Brasilia on many occasions, talk to many Brazilian colleagues about the wonderful work they were doing, often in the favela communities of Brazil. And I realized very early on it was a two-way process. It wasn't just us telling them how to run things. They had a lot of very good examples of excellent practice for us, particularly the engagement of the community, which I think British primary care still lags behind on. And one of the things that really impressed me was the use of community health workers. So these were people with only a few weeks training, 6 weeks training, but using standard protocols. And they would visit, they'd have about 150 families or so on their books, and they would visit these every month. And so they were like the eyes and ears of the family doctor in the community. So the team was the doctor, the nurse, and the community health workers. And this I found to be a very powerful model. And there's a wonderful bridge between the primary healthcare model that you see in Africa, which is don't have enough doctors, so it's all community health workers, and the very professionalized model we have in the UK and elsewhere in high-income countries. And I felt that the UK could learn a lot from that. In fact, I still do. And when I was in general practice, I often wished I'd had community health workers who could visit the people I never had time to do with sufficient frequency, and would know them better than I could ever know them, and could communicate to me whether things needed addressing, whether someone might be declining or might need particular input, and would really have been, I think, greatly magnified the kind of reach of primary care. And I still think that's a valid comment today.
And finally, let me ask you about your real passion at the moment, which is climate change, and of course, which was recognised recently with the Tyler Prize. Talk to us a little bit about that.
Well, in the 90s, really, I began to be aware, late 80s, I began to be aware of this idea of climate change. And I had this feeling very early on, it must affect human health, because I remembered those ancient treatise of Hippocrates, airs, waters, places, which I never actually read, but I thought, well, if Hippocrates thought the environment impacted human health thousands of years ago, and I've seen it myself, I've worked in different countries where there's very different disease patterns. So climate change must affect human health. And when I started writing, and nobody else was writing, but I wrote a leader in the BMJ saying if we don't do something about this, climate change could have potentially catastrophic effects on climate change. So we need to act. And of course, that meant reducing fossil fuel combustion and also making our food systems more sustainable, because they also contribute about 25–30% of greenhouse gas emissions. Well, at that time, really no one else was interested, apart from a guy called Tony McMichael, who was a brilliant professor from Australia, who eventually wrote a book actually called Planetary Overload in 1993, which is a really preeminent and very visionary piece of work. And he and I also did work for the World Health Organization, starting to put together the evidence on climate change and health. Of course, nobody wanted to fund it in terms of research, so a lot of it was opinion pieces, or we would be pulling together data from different sources. But over the years, it became much more accepted that there would be, and there are, increasingly effects of climate change on human health. And now we're focusing very much on solutions. And there are two types of solutions: the adaptation, adapting to the change that we can't prevent, and the mitigation, cutting greenhouse gases. And in recent years, I've been very much involved with documenting the benefits of moving towards a net zero carbon economy because of reduced air pollution, improved access to healthy diets, more physical activity through more sustainable transport systems. And of course, the healthcare system itself, which we recognize now is responsible for about 5% of emissions. So in delivering healthcare, we're also making climate change worse. There's also an important role there for the healthcare system. And that's very much my focus at the moment. And also more broadly, in 2015, I was asked by the Lancet and the Rockefeller Foundation to chair the Planetary Health Commission. And that looked more broadly than climate change at this concept called planetary boundaries. And at that time, there were sort of 7 known planetary boundaries. Now there are 9 planetary boundaries, and fresh water and biodiversity, novel entities, pollutants, and that is aerosols, and so on and so on. And the problem is that we've breached 6 of the 9 planetary boundaries, human society, due to these inequitable patterns of consumption. So we have to change our consumption patterns very quickly, develop much more adaptable, resilient healthcare and other systems, but also achieve human progress at much lower levels of environmental footprint than we do currently. And that's going to be, of course, a big challenge, a big political challenge, a technological challenge, and a behavioral challenge, but one which I'm very concerned with at the moment.
Andy, you started off by telling us you had a difficult birth and you kept the doctors on their toes from the very beginning, and you certainly have throughout your life. And thank you on behalf of all of us for all your work and keeping healthcare really thinking about the problems that are facing us. Andy Haines, thank you very much indeed. It's been a pleasure.
Thanks so much for interviewing me. Very kind of you. Thanks. Much appreciated.